Good evening, everyone. On behalf of Intas Pharmaceutical Limited, I, Dr. Meera Kacha from the Medical Affairs, welcome you in the 29th episode of Endocrine Talk Show. Endocrine Talk Show aims to cover various topics on the management of endocrinological disorder that matters in day-to-day practice of consultant physicians. During this talk show, we have a team of eminent experts. Those will discuss the latest scientific updates and the management challenges in the field of endocrinology, and they will also answer the various questions from the audience. Today's discussion is very much important. It is on the metabolic dysfunction associated steatotic liver disease, the emerging pandemic. And as we know, this talk show always moderated by Dr. Subhankar Chaudhary, and it's my privilege to introduce him. Dr. Professor Subhankar Chaudhary is a director of Department of Diabetes and Endocrinology, Medica Super Specialty Hospital, Kolkata, and former head of the Department of Endocrinology of the Institute of Postgraduate Medical Education and Research and SSKM Hospital, Kolkata. Sir was immediate past editor-in-chief of Indian Journal of Endocrinology and Metabolism, past president of Endocrine Society of India, immediate past president of Endocrine Society of Bengal. Sir is a member of Subject Expert Committee Endocrinology CDSCO Government of India and the founder patron of South Asia Endocrinology Foundation of Endocrine Society. Sir has more than 220 publications in various national and international journals. So I welcome you, Dr. Professor Subhankar Chaudhary, and sir, I would like to hand over further discussion to you.
Thank
Yes,
you
sir.
very much. Thank you, Dr. Meera. It's been a wonderful journey so far
Yes.
to this 28 past episodes, and this is the 29th episode of Endocrine Talk Show. And we are always benefited by the wisdom and knowledge of people, experts from across the country. And this evening is no exception. So, in order to make us more knowledgeable at the end of the hour or hour and a half of discussion, we have with us Dr. Professor Dr. Sahana Shetty, who is professor in head department of endocrinology at Kasturba Medical College at Manipal, and she has got several publications in national and international journals, and she is a very well-known name in the field of endocrinology in our country. We also have with us Professor Abhay Sahu, who is professor in of the Department of Endocrinology at the IMS and SAM Hospital in Bhubaneswar. He is an excellent person and great organizer. Has organized several important conferences in Bhubaneswar, and a very good friend of ours. We also have with us Dr. Ankur Gahlot, who is Additional Director, Department of Diabetes and Endocrine Sciences at Rukmani Birla Hospital in Jaipur. He's actively involved in many clinical trials, and he's also a sought-after name in the field of endocrinology. We will be joined shortly, yes, by Dr. Devajyoti Chakraborty. Do we have him yet? But let's introduce him, who is a consultant endocrinologist at the BP Poddar Hospital and Medical Research Center in Kolkata. So he will sort of take the gastroenterologist's question, and we'll have the endocrinologist colleagues to provide ample and more support to him. And as usual, I would appeal to all our audience across the country to put up your questions in the chat box, and which we will all try and address if they have already not been covered during the course of the discussion. So let's start with Dr. Abhay Sahu. We talk. This is a liver disease, MASLD, as Dr. Meera already has pointed out. There is a shift in the nomenclature, but still, it's a liver disease that we're talking of. So, what are we endocrinologists? Why should we be part of this program of liver disease? Should we be concerned about it? Dr. Shahu, please unmute.
Thank you, sir. It's always a privilege to be associated with Shubhankar sir with any sort of programs. And the thing is that when we are discussing about MSLD, it is not only the deposition of fat in the liver, because if you see the pathophysiology, it is the insulin resistance, it is diabetes, it is hypertension, it is dyslipidemia. All those things actually, uh, in toto, is responsible for deposition of fat in the liver. It's not only that a single thing is responsible or any just only the liver fat is getting deposited in the liver. So, in my view, that when we are discussing MSLD, it is not only it is the prerogative of the gastroenterologist, that a endocrinologist, one gastroenterologist, and also even if I'll tell the cardiologist, all have a combination thing which will actually give the best result to the patient, because the time the liver having fat is getting deposited in the liver, there is insulin resistance. Patient might have developed diabetes, or patient is on impaired glucose tolerance, or patient is having a pre-diabetic stage. And simultaneously, you will see these people are high risk of cardiovascular disease. So it is not only that looking at that there is only fat is deposited in the liver, that a gastroenterologist should take care. It is a team approach where a endocrinologist, a cardiologist, and a uh, gastroenterologist all should take care, so that if patient will get a holistic approach and patient will get the best result from that. That is my view from that.
I think I would fully subscribe, and I'm sure Shahana and Dr. Ankur would also agree. Uh, I would only like to add, maybe as part of the spectrum, we're now talking of the heart as well, cardiovascular disease beyond the liver. I think that kidneys are also likely to be affected. So somewhere in the spectrum, we also possibly need to have a nephrologist.
Yes, sir.
And then
Yeah, CKM,
because
because now what we are seeing, the CKM syndrome is actually the cardiovascular, kidney, and metabolic profile. All those things, if we are taking CKM part, probably again kidney part is also, it is actually another nephrologist should be also involved. But what we have seen, that if someone is creatinine is normal, there is no microalbuminuria, at that point of time, probably taking a call from a nephrologist is
yeah,
usually not required. But
sure.
as an endocrinologist and cardiologist and as a gastroenterologist, all three are most important for particularly for MSLD point of view.
Yes, and beyond that, I also feel that looking at the enormity of the problem, uh, possibly how many endocrinologists do we have across the country? Maybe you have more number of gastroenterologists. I think should we also not have the family physician or the consultant physicians also taking a keen interest in this issue? Dr. Shahana, what are your thoughts on that?
Yes, I completely agree because we know it's like a silently growing epidemic and the burden of disease is very huge. So it is, of course, as an endocrinologist, we probably will see patients who have MSLD plus metabolic problems. But then the physicians or the family physicians get to see a lot of these patients. So the screening may start at that level. I think there is also a national health program which was commenced. So where at various levels from primary, secondary, and tertiary care level have been this level of care has been described. So I think the screening for MSLD at least can start at primary care level, and then physicians can also be involved. And then, of course, now we have risk stratification and those things. Based on that, we can decide whether it has to be whether the patient needs to be referred to a specialist in that direction. So I think disciplinary care, and starting from primary care to a specialist, all of them must be involved in the management of MSLD.
Yeah. Another
Right.
important thing, yes, actually,
Yes.
when we were DM students at that time, probably also what you have seen, that at that time, if someone is having a elevation of SGOT and SGPT, a lot of times our teacher used to tell it's diabetes and it's nothing, don't get worried. And usually, if you lose some weight, everything will be resolved, everything, and don't get worried and such type of things. But now, in due course of time, we are realizing that probably that this is the disease. It's not that you should not ignore that. And what I can tell that 10, 15 years, 20 years back, what we are ignoring, probably we should not ignore now in this point of time.
Absolutely. So I'll come back, stay with Dr. Shahana Shetty a little while more. So in our practice, endocrine practice, which are the patients where we should be specially careful about or think about MSLD, and where should we do the next step, whatever is necessary?
So I think this answer we will get it from the definition of MSLD itself, where it is defined as patient with hepatic steatosis plus presence of one or more components of metabolic syndrome, because we now know that it is a hepatic manifestation of insulin resistance. And also, when you look at the screening guidelines, they talk about screening high-risk people. And who are these high-risk people? These are patients with diabetes, because the prevalence is as high as 50 to 60%. And we have Indian studies talking about 68% prevalence. Even patients with pre-diabetes and patients with obesity and any components of metabolic syndrome, whether it is dyslipidemia or hypertension, even PCOS. So, and then of course, you have patients who have come with an imaging, maybe a routine ultrasound done as part of health check, of some other reasons. They come with a ultrasound imaging evidence of hepatic steatosis, or has come with elevated liver enzymes. These are the high-risk patients who have to be, are the ones we generally see, and then ones who needs further evaluation in terms of further evaluation to kind of stratify the risk of MSLD, where do they stand and what are the interventions they need.
Right. So clearly, it is. Sorry. So let us welcome to our fold Dr. Devajyoti
Again, sir, I will
Chakraborty.
add that it's not only that those who are diabetic, again, those who are having Cushing syndrome, all those people.
Yeah, those will be
again,
less in number. Yeah.
Again, these are the subgroup where also we should actually focus and we should actually screen for MSLD in those group of patients.
Right. Yeah. So we welcome Dr. Devajyoti Chakraborty, who is our guest faculty this evening, the gastroenterologist in the group. And so we were talking about MASLD, and of course, it's a huge problem across the country. When we talk of screening, and we were talking of screening, and Dr. Shahana Shetty clearly outlined which are the people where we should especially think about it and screen. So does MASLD qualify to be screened? In the sense, when we talk of screening, we are talking of a disease which has a significant clinical impact, which MSH or MSLD does have, which should have easily available, acceptable, reliable screening test, and finally should be a condition that is treatable. So does MSLD fulfill all these criteria? Please unmute. Yeah. Yeah, you're unmuted.
Sorry for the disruption. MSLD is still the technologies and the tests for the screening for MSLD are still under development. We do not have we do not have very good tests till now, and those tests we use for screening, they have a high screening failure rate in studies. So it is not recommended to do general population screening. However, in high risk population groups, as Dr. Shetty said, in high-risk population groups, it is there is ample data to suggest screening of for MSLD.
Right, and then I do know there is a lot of difference in opinion as to what should be the screening test. What would be your idea of the best screening test?
The screening test currently what we do is with the current definition of MSLD, what we do is if we get two group of patients mainly when we screen actively for high risk patients, and one and the other group of patients whom we incidentally find to have steatotic liver disease on ultrasound, then we progress from there. So in this situation, what is this ultrasound is now till now for the case definition for screening, ultrasound is the basic case finding tool. So but ultrasound is not that effective because there are a lot of intra observer and inter observer variations in ultrasound, and also the ultrasound grading and staging are not accurate. Though initially ultrasound used to be ultrasound screening of fatty liver used to be defined as ecogenicity of liver and kidney, comparing both those two, and they would term fatty liver, but that has been found that has been now rejected. Now they screen using
No, so let's that's an interesting area. So if we stick to the ultrasound, so how we always get reports grade 1 fatty liver, grade 2 fatty liver. So
yes.
how are those graded quickly, if you can understand?
They are graded according to the firstly that classified into three stages, and that grading is according to the comparing with the vessels in the liver and also with the diaphragm. And but this is very much objective, and there are a lot of fallacies.
So what is grade 1? Let's accept that there is a grading. So what is grade 1? What does it mean?
Actually, it does not corroborate with the fibrotic staging and also the steatotic
No.
stage. So
Okay.
what I would like to say is that we should move away from ultrasound, and for screening we should use other NITs like FIB4. Two group of mainly. One is the imaging modalities and the non-imaging modalities. The imaging modalities are the several MR based or VCT.
I mean, MR clearly cannot be a screening test. You and I should agree. I mean, you can't do MR as a screening test across the country.
Should I add?
In some countries, like in Korea and in Hong Kong, they prefer MR elastography over transient elastography. But yeah, it cannot be in our country.
Okay, so FIB4 is your choice. So yes, Abhay, you were wanting to say something?
Yeah,
is it?
Sir, actually, my opinion is in each and every person agent, because we are as a endocrinologist, we used to do liver function test in each and every patient, and any person we got SGOT, SGBT 2 times above the normal, we classically do additional tests. So what is the grade 1, grade 2, and grade 3 fatty liver? What we have discussed and what I have found from the literature, less than 10% fat is there, usually it's grade 1. 10 to 20% is grade 2, and more than 20% is there, it is grade 3. But I have found from the literature and what day. But this is not, as Dr. Debjyoti has clearly told, that this is not a foolproof test that from where we can take a call that what type of steps we can take. But there are few studies which has clearly told that if you are going for particularly, there is a APRI score. APRI is, it is ALT to platelet ratio.
Yes.
So APRI score is one of the thing what actually lot of the gastroenterologists now are usually using, that when APRI is the cutoff is usually 0.5. When it is between 0.5 to 2 is normal, and if it is above 2, it is abnormal. Same thing that what sir is telling, that people are discussing about what classically we are
FIB4.
doing elastography. From elastography also, we can have a lot of ideas whether there is fibrosis is there or not, and also whether
Fat.
we take
Yeah.
a call. Yeah. Again,
Yeah.
there are certain things like particularly there is NFLD fibrosis score is there, from where you can take a call, because we know they are using very small things, like they are using age, BMI, hyperglycemia, platelet counts, and also albumin. From there, they will count what is the particular the score, and from that also we can get, and that will give us a
Yeah.
clear cut idea
Yeah.
whether there is
So,
fibrosis there or not. So these are few non-invasive tests. From that we can get clear cut idea, and also subsequently you can go for MR scan or anything, whatever you think, because all these are
yeah.
costly. We cannot from the
Yeah.
baseline, we should not, or you cannot, no, as a person, we cannot tell everybody that you should go for MR scan in an every
Right.
person. It's not possible.
So maybe the,
Yeah.
yes. Yeah.
Yeah.
So maybe the message for the physician will be, I mean, correct me if I'm wrong, Dr. Devajyoti. So if there is a simple fat in the liver that may not be of major health implication, but if there is additional inflammation and all that, fibrosis also, then there's a concern. And in order to pick those up, maybe your blood tests or some of the tests, including various other parameters that can be garnered easily. You mentioned, I mean, among the two of you, you've mentioned about APRI, you've talked of FIB4. Those may give us an idea. So can I ask Dr. Ankur as to which score do you rely on?
Look, one thing about, as Dr. Devajyoti was telling us, that this fatty liver diagnosis on USG is very observer bias. We know that it's a very subjective kind of thing. There is a very less objectivity in, because it will depend on the person who is doing ultrasonography and the kind of machine these people are having. So obviously we have to move ahead, as Dr. Abhay sir were telling, that we have to look for the other factors like FIB scoring, like the elastography, and these scoring and the elastography is also, it is a very sensitive tool and a specific tool as far as the diagnosis of MSALD is concerned.
Sir,
Okay,
if I
fair
can
enough.
add and simplify.
Yes,
Uh,
yes, please do.
Okay, so what's from my reading, what I understood or I will follow is that, first of all, for us to define that there is a liver fat, we need some very basic screening test. And for that, still the ultrasound is the screening test. Can we take the information only about whether there is steatosis or no? Maybe, like they said, but the extent and what is the stage of liver disease is very difficult to tell unless there is advanced stages of, unless there is early cirrhosis findings. So all the guidelines or literature, what they say is the ultrasound is just to know if there is a steatosis or no, but subsequently to risk stratify where a patient stand, whether it's in mild, intermediate, or high risk, then you do the scoring, whether it's FIB4 or other scores, which are just based on few blood parameters which you've already done on the patients. And with that, we can further risk stratify into low risk versus high risk. So those whoever have coming intermediate or those who come on low risk, we just probably keep them and follow up and do metabolic treat the underlying metabolic. But those who come in intermediate or high risk on these risk scoring like FIB4 or the other scores, then we go ahead and do further evaluation with transient elastography or the fibroscan, what we're talking about, or if affordable, of course, the MRI, the MR scans, and of course, then you have the extended liver markers also are available. So these are when they come into intermediate or high. So for practical approaches in patients, we start with ultrasound, then do the risk scoring, and then you categorize, and then probably we can proceed is what I have understood. You can correct me if I'm wrong. Thank you.
Dr. Sana, what actually Dr. Ankit and Dr. Devjit is telling, actually the thing is that whenever we are doing ultrasound, there is a observer bias, because it depends on the sonologist who is doing. If someone is very competent, probably might be the report is very good. If someone is a young one, not that much competent, probably get a different result. So, of course, ultrasound is the basic part. Classically, we do and we are doing, but probably now this is
Yeah,
the
that is not
store
enough.
and
I completely
elastorapids.
understand. But
Yeah,
that is not
Yeah.
enough, but I'm telling that is the first step. Because
yeah,
we will directly
absolutely.
not do a PIP score without an ultrasound showing a steatosis. That's what I was trying
And
to say. And fibro
and
definitely ultrasound is not
yes,
enough. I think that's
yeah,
what everybody is trying to say.
and then we need to be aware of the limitation of the ultrasound as well. The Debojyoti, did you have a point to make?
Yes, so
Did you
what
want to? Yeah,
yeah,
quick one.
what I
Yes.
wanted to say was that when we are incidentally finding patients after doing ultrasound and getting fatty liver, then it is already done. But when screening for high risk patients, especially those
Yeah.
who have altered LFT, I think we should go for though it is not yet in the guidelines, but there are data to show that CAP, controlled attenuation parameter, which is one of the parameters of fibroscan, that is a very good marker for steatosis. So that is
Yeah.
actually better than the ultrasound guidance. So we are doing the same test, only we are using two values, and with that we can prognosticate as well as start the treatment if necessary.
Right. So
Actually,
we come back.
Shubhankar sir also, sir, you also agree because in 2000 when we are doing DM at that time in even if names, a lot of times we have seen grade 1 fatty liver, we have seen and gastrologist, everybody it's normal, don't worry, it's a normal thing. उसका पेट थोड़ा ज्यादा है तो आएगा ये तो normal होता है. But now in due course of time, what we have learned that probably it's not normal.
Yeah, yeah, that's absolutely right. We come back to Dr. Ankur. So, Ankur, so can we quickly sort of summarize for us the pathogenesis of this condition? How is it related to obesity and all that? Is it all about insulin resistance?
Look, as happened with our understanding of the pathophysiology of diabetes, we started with only two kind of pathology: insulin resistance and decreased insulin secretion, and then we shifted to maybe omnious octet and multiple pathologies. And same is in MSLD also. We had understanding that it is only the steatosis which occurs first, and then the second hit because of inflammation or because of oxidative stress, and it propagates to MSLD. But recently it has been seen that it is not only these two things which are important, but other things, especially like genetic factors, the genetic predisposition for, and we have seen in our clinical practice also that some lean and thin patients with good glycemic control and grade 3 fatty liver, grade 2 fatty liver with altered SGOT-PTs. So these are the patients who might be having some genetic predisposition. Then there are other things like associated drugs which are involved, or obviously the substance abuse is also a problem. And then other things in form of severe insulin resistance or lipodystrophies or presence of other endocrinopathies, as Dr. Abe was telling, in form of
Yeah,
Cushing's disease
push.
or
Okay.
growth hormone deficiency or pituitary hypofunctioning. So all these things are there. So now it has become a multifactorial thing where we should try to look out for other factors also, not only focus only on the metabolic factors or on the steatotic factor as far as MSLD is concerned. That's my understanding.
And right. And we also talk about the gut microbiota. I mean,
Yeah,
I think
absolutely.
we link it to so many all types of diseases, but at this point of time, I don't think we have shown that uh, treating or altering that microbiota, or neither do we know exactly how to do that, that it actually influences the disease course that we are associating with. And you name anything from neurological conditions to metabolic to everything, gut micro. And similarly for MSLD also, it is being implicated. Right. Okay. A very important issue, Dr. Devajyoti, is how do we identify a patient who is likely to progress versus who is not likely to progress? Can we do that? Is it by those indices that you mentioned?
Yes, now the current evidence suggests, current data suggests that all the progression of the disease is mainly we have like the incidence in general population is, as Dr. Shetty said, it's around 25 to 30%, and in high risk groups it's around 50%. And but the
sorry, so what does that mean? 50% in what time period and progressing from where to where?
No. So that's what I was saying, going to say. These are all MSLD patients. Among these
Yes.
MSLD patients, around 20% are only MASH patients. That is MSLD with steatotic hepatitis, metabolism associated steatohepatitis. So the progression from stage to stage is much more rapid in case of MASH patients and than MSLD, normal
Okay.
non-inflammatory MSLD patients. So
Mhm.
stages of fibrosis are also more in these patients. So the progression rate, what we are looking at is probably from one stage to another, it takes around 14 years in case of MASLD, whereas in case of MASH, it is around 7 years for from progression of one stage of fibrosis to another. So we have existing NITs, that is a non-invasive test, and for the with the help of that, the different strategies have been developed to screen for high risk for progression of this disease. And also the treatment response. So the most good quality evidence is in favor of fibroscan. So fibroscan, if there is a reduction in 20%, it actually it corresponds with resolution of MASH or one stage reduction in fibrosis. This has been come across in a new cohort study. So 20% reduction of fibroscan or 20% worsening of fibroscan should be can tell us about the progression of the disease. Now the question arises, when should we repeat this fibroscan? So it has been found that fibroscan is a quite stable parameter. This LSM is a quite stable parameter. It does not change overnight. So around when patients were followed up for
And
15 months.
what about the inter-observer variation? Will it be okay whether I do, you do, anyone else does? Is it
Yes,
relatively
there are
okay?
two things. There are two things. Firstly, what I was telling was about the progression monitoring. So progression
Yes.
monitoring should be done at least 1 year gap. So it has been
Okay.
shown in a study that when they followed for 15 months, that around 96% of the patients remain stable over a period of 6 months to 8 months. To see a difference, we can at least have to repeat it after 1 year. Now coming to your question, that there are two issues. One is the technical variability. Technical variability is the different kinds of machines that are being used. So that is one of the problems. So for individual, when we are seeing individual patients, we are managing individual patients in a real world scenario. So what we should do is we at least what we can do is ask the patient to get the test repeated from the similar machine or like that.
Okay.
Till now, the most of the studies are from fibroscan, but we all know that there are several types of machines are available, and they have a separate type of calibration, and that is a problem. But
But
another
but
thing,
but the individual, the subjective factor is less, as you say,
yeah,
compared
it
to an
is much less
ultrasound.
because we have
Okay.
that interquartile range. So it is mentioned in the report. So if the interquartile range is more less than 25%, then we can see that there is and the 10 readings are taken. We can ensure see these two parameters, and then we can at least be sure that this is a quality report. Uh,
Okay. Good. Okay. So, Dr. Shahana, so why should we bother about MSH so much? I mean, what are the complications that it can lead to?
Yes. So, yeah, when we say MSLD, of course, we think of the liver-related complications. We're talking about progression to steatosis and fibrosis. Of course, the small risk of hepatocellular carcinoma. But I think as an endocrinologist, and also when we look at the data, what we see is that one of the most important cause of mortality and morbidity in these patients is cardiovascular disease. The metabolic complications are also very, very important, and especially because we're talking about high risk groups, and these are the patients. And also when I said that what the high risk groups where we need to definitely screen for MSLD, because these patients not only have a higher prevalence, but they also have a higher risk of progression to the other advanced stages, and also higher risk of associated complications. I think we just did a meta-analysis which is going to be published in World Journal of Hepatology this month, probably to be published. So there, what we did is we looked at patients with diabetes with MSLD and without MSLD, and looked at the risk of cardiovascular complications. And what we found out, the risk was higher in patients who had diabetes plus MSLD versus those who had only diabetes. So the metabolic complications are also higher. So of course, when we identify the patients, whatever stage there is, one is that, of course, we'll try to risk stratify, like Dr. Mentioned about how you would do an elastogram and then look at the risk of fibrosis and then treat accordingly. But then we can also, it's also an educative tool to the patients to talk about, look, you also have this metabolic complication in the liver, and the need for changes in the lifestyles, the need for optimizing the glycemic control or lipid treatment of dyslipidemia, hypertension, so that overall you get a good metabolic control and thus reduce the risk of cardiovascular disease, ASCVD, and the metabolic complications as well.
Okay, good. So shall we have one final word maybe from Dr. Devajyoti? So we talked about screening. So for diagnosis, what else do we need? Do we go for MR elastography?
No,
What do we do?
That I'd like to clarify what I was saying previously. Actually, we need screening in two kind of situations. One in case of high risk groups, and
Yeah.
another when we are recruiting for studies. So when we are
Yeah.
recruiting for studies, we need a gold standard text.
Yeah.
That
Yes.
should not be a shaky one. So in that situation, MR elastography and MR PDFF was developed for that. Because we agree that it is not possible to refer to a patient for MR elastography for a test that when we are not going to be able to give them some definite treatment, or will for some explaining them the cost. MR elastography is mainly for recruiting. Now the problem, we have screening tests which we can use in the high risk group, but it has been found in the studies that these tests have a very high screen failure. So there is currently a gap, because when these patients who have been screened with NITs, they are being sent for liver biopsies. It has been found that approximately in multiple studies, it has reached up to 70% that they are biopsy negative. So when we are, so that is the reason they are not, population screening is still not recommended. So
okay. So that's an important lesson. Yeah. So even if you are screened positive, it does not necessarily mean that you got histologically proven disease. Okay. I thought maybe you would be missing out on some. Maybe the sensitivity of the test is low, but even if you're positive, you may not actually have the disease. Right. Okay. So let's come to treatment and spend the rest maybe half an hour on treatment. So first of all, of course, is lifestyle measures that we all talk about. So Dr. Shahana Sethi, how effective is that? What do you advise?
So if you actually look at all the treatment which is available, I mean, the treatments which have looked at MSLD, I think one of the most important thing which has really shown significant benefit is weight reduction. And then this could be in any form. Of course, lifestyle modification and weight reduction has shown significant improvement in various stages. So even a minimum weight loss of around 3% can bring about changes in at the level of fatty steatosis. And for inflammation, you would need a weight reduction of around 5 to 7%, and then at more than 10% weight reduction, even there has been studies showing improvement in fibrosis. Intervention where you're focusing on weight reduction, I think, is very, very important. Very important modality, and one of the first line management in patients with MSLD. Especially, we know that it is also effective to handle the metabolic complications, what we are concerned of in these patients. So lifestyle, very, very important. So if you look at when we talk about lifestyle, what are we referring to? Of course, we always talk about nutritional diet modifications and physical activity here. So with respect to diet modifications, again, there are studies, but various types of diets have been tried. But calorie restricting diet is one which is definitely the most beneficial one, which has shown weight reduction and improvement in MSLD. And with respect to physical activity, again, you have studies on aerobic exercises, resistance training, or high intensity exercises. All of this have shown benefits if it is done for a prolonged period. Some studies have done it for 2 days in a week, some have done 5 days per a week, but most of this lifestyles have shown that if there is a weight reductions, and then even with minimum weight reductions with these interventions, there is significant improvement in and of course,
Right.
like we know, metabolic complications also improve.
Right. So the two additional questions we need to address, I thought. One is it's fat in the liver. So intuitively, what people would think is then you restrict fat in the diet. What about carbohydrate-rich diet? Many of our patients, rural people, they have a very rich carbohydrate-rich diet, but not so very fat-rich diet. So what do we advise them?
Yeah. So most of our, I think, diet, I think when we're talking about calorie, in many of our patients, it is from the carbohydrate. So we definitely have to focus on reducing the carbohydrate intake, talk about whole cereals, and then talk about increasing the fiber and protein content so that the carb proportion is taken care of. So, and of course, fat also we need to advise. But like you said, the major concern in most of patients is carb, and that has to be focused on.
Right. The other part was non-obese MSLD or MASH. We have already had reference to this condition. So, or do we advise them if, let's say, the BMI is 23? So, do we ask them, so go down to BMI 21, it will help you? Is that what we advise, or how do we approach that?
So in lean MSLD, of course, when we're talking, probably we'll not talk in terms of weight reduction. But definitely, even in lean, there are studies where they've shown that if you're talking about 3% weight reduction, also there is improvement. But we need to focus on, again, whatever we talked about, like dietary modification in terms of restricting carbs, restricting fat, increasing the fiber, and physical activity. I think there are some studies where they looked at physical activity, and then they found that even if there was not significant changes in the weight, there was still improvement in MSLD. And of course, we know that in these patients, even the metabolic parameters improve. So talking about the lifestyle changes is important in this population as well.
Yes, sir.
Right.
Actually, what Dr. Sana is telling absolute right, because in that group of patients, weight loss is not important. You need to do some physical activities to reduce the insulin resistance. Once you're reducing that,
also helps.
probably that is giving benefit. So weight loss is not important in those group of patients. Dr. Sana was telling is absolutely, I'm agreeing with.
Right. So I'll just add another bit of it, because every patient, I don't know, they ask Devojyoti, but they of course ask, what about time restricted eating? Does it help? Will it help? Intermittent fasting.
Ultimately, again, it depends on calories, I think, sir. So when we say intermittent fasting and we look at our patients who talk about intermittent fastings, there are different types of what they follow. If they're doing intermittent fasting and simultaneously restricting calories in the time when they're eating, then that is definitely going to be beneficial. But then many of our
Sorry, we lost Dr. Sana. Maybe she'll join back later on. So we continue with.
If you see the intermittent fasting versus calorie restricted diet, if you see from the diabetes point of view, probably both are same. There is no difference if you are going for intermittent fasting and if you are going for calorie restricted diet. But here the call is whether we are losing some weight or not. If we are comparing intermittent fasting versus Atkins diet versus all sort of this what nowadays we are discussing that is a total whole protein diet or that is keto diet.
Ketogenic, yeah.
Probably keto diet has to weight loss, but again, Misa was to tell that we don't know the long-term complications of cardiovascular complications of keto diet, because studies are clearly showing those who are on keto diet, probably their cardiovascular complication is high. In the reverse way, those who are on only 100% protein diet, their renal complications is little bit higher in comparison to normal population. So again, what is thing, intermittent fasting is good, but a balanced diet where carb, protein, fat, everything is there, probably the best thing for what we can discuss.
Right. So we continue our discussion. We go on to pharmacotherapy, and I would once again request our physician colleagues to send in your questions so that I can address them to our expert panel this evening. So coming to the drugs that are used, there are so many of them. So one of the earliest ones that has been used, and I think has been quite popular with gastroenterology. So can we ask Dr. Debojyoti Chakraborty about the use of ursodeoxycholic acid? It is widely used even today.
It's a very interesting and controversial as well topic. So what is that this ursodeoxycholic acid is uh, um, a hydrophilic bile acid. So bile acids are, as we know, they are the end products of cholesterol metabolism, and they are synthesized in the liver, and then they are secreted in the bile, and it gets converted by the intestinal microbiota into secondary bile acid. So ursodeoxycholic acid is a secondary bile acid, which is normally present in human bile in only 5%. Constituent. But it has been found that if we take ursodeoxycholic acid from outside, that is as a drug, then if we change the bile pool into a more hydrophilic type, so there have been animal model studies on the basis of which this was used. Animal model studies which have shown things like decreased apoptosis, stability of mitochondria, and cholinergic effect and all that. But there have been multiple.
My physician friends want to know whether I will advise ursodeoxycholic acid for my patients.
No.
No? Okay.
No,
Fine.
RCTs have not been suggestive, and
Fine.
no guideline recommendations are there.
So the next step is obeticholic acid. So Dr. Abhay Sahu, I do remember during the COVID times, there was a review by the FDA, sort of premature or early review of the obeticholic acid data, and they didn't approve. They wanted them to complete the trial. So quickly about obeticholic acid.
Again, sir,
Should we use?
still obeticholic acid, people see the reduction in SGOT and SGPT. Of course, there is some data is there where they have shown that that is reduction in SGOT and SGPT. But frankly speaking, that whether there is reduction in fibrosis, reduction in inflammation, still they have not shown in the study. Again, obeticholic acid still we can use in a benefit of doubt, but again, it's not a recommended thing for particularly MSLD cases. Is like what we have seen in the pioglitazone cases, because if you see pioglitazone again, pioglitazone probably better than obeticholic acid, because if you see the pioglitazone, there is weight gain, but there is a de-differentiation of actually visceral fat to subcutaneous fat. So what happens? All the visceral fat usually differentiate to the subcutaneous fat. So automatically there is increase in subcutaneous fat, visceral fat comes down, liver fat comes down. So if you see, probably pio is actually a better choice than obeticholic acid. If you see the data point of view. But from a fibrosis point of view, if you see analyze, probably obeticholic acid is not good. Again, pio also has not shown that much data showing reversal of fibrosis. What I can tell.
My personal feeling was that obeticholic acid did show some fibrosis data, which were reasonably impressive. But one of the concerns for me was that it increased LDL cholesterol, and as we all understood that this is also a condition that increases cardiovascular morbidity, so that may not be the best drug. So let's talk about vitamin E, another agent widely used, maybe less so. Dr. Ankur, where would we use vitamin E? Is there a role?
Yeah, look, there have been studies, Niven's trial, which was done in 2010, and I think the study was published in NEGM also, which compared the vitamin E versus pioglitazone in non-diabetic patients with MSLD or NFLD, and it has been seen that the decrease in the ALT, AST levels was more pronounced with the use of vitamin E as compared to the pioglitazone, and so was a reduction in the steatohepatitis also. But unfortunately, the fibrosis score did not improve with any of the molecule.
And sir, here actually with vitamin E is that you have to use 600 milligram. 400 has no role. And
Yeah.
if you're using 600 milligram,
600 to 800 milligram.
after 1.5 to 2 months, there is some bleeding diathesis. Actually, you will see all studies, they have shown that after 1.5 months or 2 months use, there is some bleeding diathesis. So that is again a constraint for particularly long-term use of vitamin E. That is the basic problem.
I think this study in these studies, the average dose of vitamin E which was used was to the tune of 600 to 800
Yeah,
milligrams a day. So
not
more than
400.
1000
Not
is
400.
really a problem. We can't use it for too much of period. But they
Right.
have shown, the study has shown the differences, the improvement in the AST, ALT levels and the steatohepatitis, but not in the fibrosis scores.
Absolutely.
Right. And there was some long-term studies, maybe not part of this MASLD or NASH study, which linked vitamin E use to prostate cancer in men. So there is some concern long-term also. So what about our homegrown saroglitazar, Dr. Shahana Sethi? Shall we use it? Please, yeah, you need to unmute.
With respect to saraglitazole, I think of all the molecule we talked about, saraglitazole has shown some benefit. Of course, we have studies from India. Most of the studies, initial studies, were with this very less number of patients, and also the duration of studies were less. But they did show improvement in liver enzymes and the fat content. One of the concern I had with the studies is, of course, because of like we already discussed, how difficult it is to diagnose, especially with non-invasive tests. And most of the studies actually they had took I think the fibroscan was what was used for diagnosis. But in that, when people who were diagnosed on fibroscan, there was a documented evidence. You have real world evidence study, 52 weeks study of saraglitazole. I think Dr. Sujit Chowdhury, who has shown that there is significant improvement in the steatosis and also the liver enzymes. And we do have experience of using it molecularly even before it was approved for MSLD, for diabetic dyslipidemia. So, and it also targets hyperglycemia and then diabetic dyslipidemia. So it is something we can think of. Of course, I think we need more studies. There is a small biopsy proven studies which did show some improvement in inflammation and fibrosis, but the number was very less. Maybe if we have more biopsy driven studies where they specifically looked at inflammation and fibrosis with larger number of patients, then maybe we'll get better clarity. But as of now, it looks something we can use. Again, the problem of follow-up of how long to use, I think the guidelines talk about at least 1 year of use. But I think Dr. Divyajyoti has already mentioned about the problem with following up these patients. So those concerns still remain, but this is a molecule we can consider, especially if you're talking about MSLD in patients who have diabetes, diabetic dyslipidemia. This is something we can consider.
Right. So I think Dr. Ankur and Dr. Abhay, the endocrinologists are on the same page. Would you also be using saroglitazar, Dr. Ankur?
Yeah, yes. Obviously, we have seen some good data.
Okay.
And the
Okay.
study in US is still ongoing, and there it is
Yeah.
not for a diabetic patient, for without diabetes dyslipidemia. So I think
Mm.
there are good
Sir,
there are some.
but whatever the Sarepta study will see, in nowhere they have shown the reversal of fibrosis. That is the biggest challenge for
Not.
Sarepta.
There, there
Yes.
is
Yes. They were
Only
taken.
the only thing, only molecule which has shown reversal is resmetirom. And again,
Okay.
semaglutide is now they have shown that in their study that there is reversal of fibrosis. So again, saroglitazar, of course, the marker for if you will see SGOT, SGPT, there is significant reversal is there. Inflammation is coming down, but if we discuss about MSLD, probably we think that if there is reversal of fibrosis, probably that will give the best result to the patient. In that case, probably saroglitazar is not given. That is the reason why still saroglitazar not got the USFDA approval. The reason is because they have not shown any reversal in fibrosis. Only
Yeah.
drug
So
Yes.
there's a
Yeah.
that data is lacking. Correct. The data is lacking, but
Yeah. Yeah.
it's not absence of. It is not. There are no studies showing that it is not showing fibrosis. There are only very small
that is
studies
no,
showing some
actually
change,
they
but
tried to show, but actually they did not get any
Right.
reversal of fibrosis. And
Right.
only
Yeah.
studies desmetaram is going giving reversal, and another is semaglutide is again semaglutide study has clearly shown there
Yeah.
is reversal of fibrosis.
Yeah.
Again,
So can we have Dr. Devajyoti on first saroglitazar?
The saroglitazar, as we all know, there is a dual PPR inhibitor, agonist molecule. So the data on saroglitazar, as it has been said that there are only two data on the histological improvement. The first is the basic trial, that is the evidences 2 trial, where it was shown that there was a NFLD activity score improvement. But there is a large data from India, which is from Delhi, Dr. Sarian's Institute. So that is evidences 3, that is not yet published. It has been shown in the it has been presented in the conference. Though they have shown that there is improvement in fibrosis score of 1 stage if it has been used more than 52 weeks. So I think that will get published within
Okay.
next year.
Fine. Good. So what about SGLT2 inhibitors? Dr. Abhay Sahu, do you
yeah,
see their role?
sir, as an endocrinologist, you know, Dr. Sanano, we have used a lot. We know that once we are using HL plus, there is a weight loss of around 5-6 kg, and that gives a drive for particularly reduction in body weight and reduction in the hepatic liver fat. But on top of that, you will see there is some lot of additional factors from the directly from HGLT2, because you will see the study of HGLT2 where they have actually tried to see what happening to the particularly MSLD cases. They have postulated there is reduction in inflammation, there is reduction in actual endogenous reticular stress, oxidative stress is coming down, but the hepatic beta oxidation is increasing. Because once the hepatic beta oxidation is increasing, probably that is giving a additional benefit, particularly from the patient point of view. Again, what SGLT2 studies have shown, there is reduction in SGOT activity. From the fibrosis point of view, there is small reduction, but still all studies of SGOT has not shown a equivocal reduction in fibrosis. So again, what I can tell from particularly like saroglitazar, all studies has clearly not shown SGLT2 can give reduction in the inflammatory markers, but fibrosis point of view, probably it is not giving that much benefit. So that is improvement is there. But again, if you ask, sir, that if someone is having fibrosis and someone is having cirrhosis of liver, reversal, probably.
Right. Yeah. So the clear message is at this point of time, probably we do not have significant evidence in favor of. There are small evidences, but not significant enough to suggest them as important treatment consideration in MSLD. So, Dr. Abhay Sahu has already mentioned a couple of times about semaglutide. Dr. Sahana Shetty, what is the basis and how good is GLP-1 based therapy for MSLD, given the fact that most studies have shown that we do not have GLP-1 receptors on hepatocytes or the hepatic stellate cells or the Kupffer cells, which are the most important cells that are involved here. There are some studies which have suggested, yes, there are GLP-1 receptors even on hepatocyte, but mostly I think the answer or general understanding is there isn't any significant expression of GLP-1 receptor. So any effect of it will be indirect effect.
Yeah. So far, I think there are studies, of course, which have shown improvement in MSLD. and mostly they are in diabetic populations, and but just studied. We have data with liraglutide, semaglutide, and also now with tirzepatide, the Surpass 3 trial, there is a subset where they looked at it. But again, when the mechanism of action, so far whatever is discussed is more in terms of insulin reduction in body weight and insulin resistance, and not directly on the hepatocyte as such. And also, like I said in the initially, whatever interventions, if there is a significant amount of weight reductions and the weight reduction is more than 10%, we do expect changes in the liver histology as well. So again, when we talk of these molecules, we cannot. I mean, the response to weight varies from patients to patients. You can have patients who may just lose 1 or 2 kgs. The patients who lose 5 kgs. The patients who lose 10 kgs. So those who lose higher and higher the weight reductions, again, the data shows that the improvement in the liver parameters or the changes are also better. So in that way, weight reduction and insulin resistance, targeting the insulin resistance is the mechanism so far which has been attributed to GLP analogs or even tirzepatide mediated improvement in MSLD. But whether you would use it only for the hepatic complications, like whether it is, suppose you have a patient with MSLD and comes as high risk, is a high risk, and then whether it will show improvement in those stages, we don't have data. But if you have a patient who is diabetes, is obese, and having MSLD as well, of course, then of course this molecule would be helpful. And higher the weight reduction, higher is the benefit in the MSLD component as well, is what is known so far.
Sir, I want to add something because, sir, recently 2 trials with semaglutide has been published. Soul and Flow, both has been published. But Soul and Flow, if you see, 10% of the population of Soul and Flow have equal weight reduction in comparison to semaglutide versus placebo. They have lost that much of weight. But if you see the cardiovascular benefit, if you see the renal benefit, they have not got that much benefit.
The placebo group.
Yeah, absolutely. If you see that in the placebo group, 10% of people have that much weight loss. Despite of that much weight loss, they do not get that much benefit, cardiovascular benefit. The reason is probably this is the innate property of the drug, but actually giving the benefit. It's not that the only weight loss which is actually transforming to that part. So what I'm agreeing with Sana, but again, what I will tell, if you see the trials of SGLT2 and also GLP, despite of a advance of 8%, still these people have got cardiovascular benefit, renal benefit. What does it intend? That it's not only the blood glucose control, it's not only the weight loss. Despite of that, this is the innate property of the molecule which is giving the benefit. So semaglutide has its own innate property which is actually giving benefits from the liver point of view. It's not only the weight loss, it is the
Fair point. Yeah. So beyond weight loss, there may be additional effect which we have not understood yet. So can I come to Dr. Ankur Gehlot? We are coming to the end of this show. So can we talk about resmetirom? We've been waiting for one drug, and US FDA has to approve, and then you have passed the test, then you can use it. So do you think resmetirom has now solved all the problems and we should be going ahead and getting resmetirom? Today, it's not marketed in India, but on an individual patient basis, you can get it imported.
Yeah, look, I will tell, I don't have any personal idea. So,
does anyone have in this group? I don't
Sir,
have.
I have worked on, I've done a meta-analysis on resimetron, which is published in scientific reports. We did on the phase 3 randomized controlled trials. So here in this study, it was only these were the first 3 studies which came up before the Maestro study, the NASH Maestro study. So here they only looked at the MRI PDF that is talking about the fat fraction in the liver, which showed definite improvement in fat fraction at both 50 mg and 100 mg doses. And then subsequently, I think NEGM, there came a Maestro NASH study where they also showed histological improvement and changes, and then reduction in the fibrosis score. So that, and I think there's another study also coming up. I don't remember the name as of now. So the data looks promising. And even if we have looked at the side effect profile also of these studies, and then mostly it was either most GI complaints like nausea, vomiting, or diarrhea, which was reported no significant. Let me complete, Dr. Abhay sir, and then you
Dr.
can.
Khanna is telling absolutely right. Actually, two
Yeah,
of our
can I
patients
complete,
are
Dr. Abhay
increasing.
sir?
Yeah, two of our patients
Yeah,
are
yeah, yeah,
creatinine
yeah.
has increased.
Abhay, yeah, yeah. Let Shana finish.
Yeah. So, but what I did, I mean, of course, the studies have shown that. But when it comes to clinical practice, I think the problem will be to identify who are the patients we're going to treat. Like if you're talking about a 50% prevalence of MSLD in our type 2 diabetes patients, who are the ones we need to treat? That is something which is still not clear. And I'm happy if Dr. Jebajoti would be help us in these directions. Of course, if you ask me, then maybe I will look for those who are progressing towards inflammation and fibrosis, because those are the patients I would pick and treat. But again, we have understood the challenges of identifying this, because we don't really have a very good standard diagnostic test for this. So this is a challenge. Although these molecules have shown benefit, of course, and then more data may come in, but this is a challenge probably for clinical practice.
Yeah.
Yeah.
Sana, what you have told actually in our center, in this study, actually we have given 49 patients. Two of the patients have creatinine increased, and we have reported that. And again, if you see the study material, they have shown there is a chance of increasing creatinine in those group of patients. Otherwise, everybody tolerated very well. There is no problem in any of the patients, but two persons creatinine increase, so we have reported that two patients.
Okay. So that's something that I wasn't aware of, that it can lead to increase in creatinine. Yes, Devajyoti,
Yes.
any thoughts on resmetirom?
What Dr. Shetty asked that which patients we are going to treat. So we have a Baveno consensus and recent data which show that treatment should be afforded to patients who are overweight and with an LSM value of more than 15 kilopascals and less than 64 years of age. That is the cutoff of 15 kilopascals should be taken in case of patients who are overweight or more than 64 years or with diabetes or with this high risk group. And in case of those with not with this in the high risk group, the cutoff should be around 12 kilopascals. But the problem is we have with LSM values, we have a gray zone of 8 to 12 kilopascals. We don't know what to do with these patients. Because there is no data on that, and we cannot recommend all these patients to liver biopsies. Suppose we have a patient with very high liver enzymes, and the LSM value comes around 9 or 10. Then should we start treatment in these patients? That data is lacking. So there has been a recent cohort study which had shown that if we incorporate both CAP and LSM, then we can at least rule out those patients we do not need to treat. If the CAP is less than 280 as well as the LSM is less than 10, then we can say that the treatment we can avoid treatment in this group of patients.
Okay. So I had an impression, maybe you can correct me, that as the fibrosis progresses, maybe the cap also comes down. Does it not? I mean,
yes. But in between, we have patients who are with inflammations and early stages of fibrosis. So that
right.
is
Yeah.
so,
Right.
And also, we don't
So,
have a long-term data of whether it is really going to affect the end point complications like cirrhosis or hepatocellular. We're only talking in terms of histological change. And then,
absolutely.
but when we don't have really a long-term data that it really
Then
is going to help.
Again, Sana, if there is histological changes, probably we are giving benefit. Only reduction in SGOT, LGBT probably is no way we are giving the benefit. If there is histological improvement, definitely there is benefit. So
Yeah.
if you
Yeah.
see all
That's
guidelines, probably the gold standard is histological improvement.
yes.
So if
But
you
at
are
least we need some
uh,
long-term study, because
yeah,
most studies are
yes.
1 year,
Yes.
2 year, 3 years like that.
so
Yeah.
if you are getting histological improvement means there is no confusion, getting benefit. But
No,
only
but
markers improvement, probably it's not the choice, or probably we are not solving the problem.
yeah, but I do agree with Shahana that we also need an endpoint study. You need to show that just lowering the cholesterol, even lowering maybe ultrasound measured plaque volume reduction is not enough. We need to show that there is reduction in heart attacks, there's a reduction in mortality, reduction in stroke. So similarly in this also, I would be happier to get actually endpoint results, which would give us more confidence. It may be, it will show, but we do not have that. So finally, maybe the final one for Dr. Debojyoti is, how do we monitor someone with MSLD?
So we have, as I mentioned, that we have two types of NITs. That is the biochemical tests and the imaging tests. And we have a group of scores which have come up recently, which are a mix of this biochemical tests and imaging tests. So for as I mentioned, for screening, we have a set of tests, and among them, the recent
No, for monitoring,
for
someone who, yes, so
for
long-term
monitoring,
monitoring, yeah.
for long-term monitoring, till now, LSM values are the best. And for short-term monitoring, an ALT level decrease of 17 up to 17 unit per liter is a good marker of decrease in correlates with histological improvement in inflammation. If we have a patient with raised liver function, ALT, then a decrease in 17 would be good. And
Okay.
uh,
Do we not need to monitor for hepatocellular carcinoma? Do we need to keep
yes, we
that
need
in
to
mind?
monitor for, yes, that's for long-term events.
Yeah.
Yeah, but for LSM
So
monitoring, for
yeah,
LSM monitoring, if we do an LSM monitoring, and it has been shown that liver-related events, that is decompensation and hepatocellular carcinoma, they both correlate with worsening of
LSM.
LSM values.
Okay. So we don't need to do a separate biomarker for hepatocellular carcinoma. Alpha fetoprotein or something, we don't need to do.
If it is it reaches up to compensated cirrhosis, then according to the cirrhosis guidelines, we need to do ultrasound and alpha fetoprotein. Yeah, but before that, there has still not been recommendations. Though there are
Okay.
non-cirrhotic hepatocellular carcinoma is on the rise, but still
Okay. Right.
there
So,
has
and,
no.
and of course, the cardiovascular monitoring, the metabolic monitoring also needs to be done, because these patients may become diabetic and are likely to have abnormal lipids, which need to be addressed. So we do have some questions here. So quickly we shall try to address them and then wind up. Are there any emerging biomarkers that hold promise for early detection of MSLD? Would Dr. Debojyoti have anything new to add?
For MASH, we have that FAST. FAST is very good. It
Okay.
includes FIB4 as well as LSM.
FAST is a combination of
LSM,
AST,
AST,
AST
and
and also LSM.
LSM.
Right. Okay.
That's very good, and it shows it can be used for monitoring as well. A 0.4 reduction correlates with LSM values.
Right.
Histologically.
And maybe Dr. Ankur, what unique challenges do Indian patients face in MSLD screening and follow-up care? Maybe from your experience, whatever you feel.
Look, I think one thing is good as far as Indian patient is concerned, that sonography can be done very, very easily. So if you really look for a American patient or a European patient to get a appointment for a sonography, it would be a very hard thing to do. But in India you can do it very easily. But as Dr. Devajyoti was telling us, because the sensitivity of sonography alone is not poor, so what we need to get is the circumstantial evidence: the presence of obesity, the presence of metabolic syndrome, the presence of dyslipidemia, the presence of raised AST ALT levels. So all these things, if we can screen properly, then we can always at least have a fair bit of idea about our patient, that which patients are predisposed to getting MSALD and progression to basically MASH or something else, and which are the patient who are at a lower risk. So most of things are circumstantial. You need not to prove it, but a good history, but a good the parameters or the comorbid conditions for the patient would give us
Right.
a fair idea for our most of the patients. So there is no need to go for very costly test for most of the patient. But of course, when we see the progression, the risk of progression is there, we can always go for those tests.
Right. And I possibly would need to add that in India, we do see not large numbers of people who are non-obese but have fatty liver disease or MSLD. So we need to be aware of that as well.
In
And
cohort,
yes,
in cohorts, the data has been that it is around 10%. In Indian population, lean MASLD is around 10% of the in cohort groups. So
yeah.
that is
So
very important.
right. And the final question we have is how has, and maybe any or all of you can quickly put in or pitch in your views. How has the redefinition from NAFLD to MASLD changed your approach in clinical practice? Quickly, Devojyoti.
As per data from studies, NFLD and MSLD are same. We can use all the NFLD data for MSLD.
Okay, okay,
Studies have shown that. And
okay.
now the important thing is that the new kid on the block, that is the MET ALD. That is previously either you had alcoholic liver disease or you had non-alcoholic liver disease. Now you have patients who are non taking some alcohol and they have a separate natural history. That is MET
So,
ALD.
how do you diagnose that quickly?
By history only.
Yes.
For
By
alcohol,
history.
for
By
alcohol,
history.
50 to 60 grams for alcoholic liver disease per day, and for
But we all know the reliability of history in those who take alcohol, don't
yeah,
we?
but previously it would be that if you don't take 50 to 60 milligram per day of alcohol, then you are NAFLD. But now,
Okay,
if you take more than 20 to 30 milligram per day alcohol, then it's
grams,
made ALD.
right.
And these
Okay,
patients,
okay,
huh. And but another thing is that those patients who are further down with alcoholic liver disease and with metabolic problems, they are separate. They are not met ALD. That is alcoholic liver disease with
okay,
metabolic risk factors and MET ALD and MASLD. These three are the similar.
okay, okay, okay. Would the others have anything to add? Chana?
Yeah, so I think the main idea of changing the nomenclature is to stress upon the metabolic complications. Because although when we say NFLD, we only think of liver-related complications. But when you look at the actual the long-term follow-up, I think CVD, cardiovascular diseases, has been the most important cause of mortality in these patients. So to highlight on the need for the addressing the metabolic complications, I think this the terminology was mainly changed. Of course, the liver part remains the same, the management remains the same, but in addition, focusing on the metabolic risk factors with its obesity, and of course, and then also the interventions which have shown benefit in these
Yeah,
directions when you're targeting the metabolic. I think that's the main reason for change in the
sure.
nomenclature.
Yeah, yeah. Abhay, would you have anything to add?
Yeah,
Otherwise,
yeah. Actually, sir, what Sana is telling is absolutely I'm agreeing with her. Again, but now the nomenclature, whatever the nomenclature you could see, diabetes, AIDS, everything. The thought is that you cannot discuss or you cannot give any nomenclature which will harm or it will socially, it will give some
yeah,
sort of
Stigmatize the
harm.
patient.
That's the reason why alcohol has been removed from that. It's not only the metabolic thing, because if you see, you can tell the people with diabetes, you cannot tell a patient is a diabetic. You cannot, similarly,
yeah,
it is that metabolic complications of diabetes, you cannot tell non-alcoholic, because whether someone is taking alcohol or not alcohol, it is a personal thing. You cannot stress upon that. That is the reason why actually they are shifting focus or in that way, so that nobody should get harmed, or thoughtfully they should not get harmed. That is the reason why, again, yeah.
yes, yes. So, but of course, it's important to understand that there is a significant metabolic dysfunction that we need to address issues even beyond the liver, that is a very important message. It's not just about the fatty liver, it's the rest of the problems as well. So I think we had a wonderful discussion this evening with all our panelists. A very sincere thanks to Dr. Debojyoti Chakraborty, Dr. Ankur Kailot, Dr. Abhay Sahu, Dr. Shahana Shetty, and of course to all our audience all across the country. I usually get some numbers from Intas team as to how many logged in. I didn't, but thanks to all of you and for asking those important, intriguing questions to our panelists. So overall, we do understand that MSLD is now a huge problem, a developing problem. Probably we haven't seen the entire picture of it, and it requires a multi-pronged approach. It requires, of course, a great sort of suspicion, first of all, from the physician level itself, the family physician, so that they can then identify, screen, and refer. And then, of course, I think endocrinologists, gastroenterologists, and beyond that, cardiologists may or may not be, also nephrologists may need to be involved sometime in the course of the disease. And we are having new medicines available, uh, some of which are not yet marketed in India, but could be made available. But still, it's very, very costly. I don't think it's worth a try for most of our patients. But even without that, I think we need to focus on the metabolic aspect and try and get the best health out of our people. And with that, and of course, with very good news that we had earlier in the evening of the ceasefire, and we do hope we all stay safe, as also stay as proud Indians. So with this, I hand over back to the INTAS team.
Sir, I must say it was a wonderful session, very informative session, and we have more than 1900 attendees. And as we conclude today's session, I would like to extend our sincere gratitude to Dr. Subhankar Chaudhary for nicely moderating, covering all the aspects, like starting from screening to management in today's discussion. I would also like to thank all the panel members, Dr. Abhay Kumar Shahu, Dr. Ankur Gehlot, Dr. Shahana Sethi, and Dr. Devajyoti Chakrabarti for your valuable contribution and active participation in today's discussion. It has truly enriched our collective understanding. And a big thank you to our audience for their active participation and management. We hope you found this session informative and valuable. We look forward for your continuous engagement in the future sessions. Until then, stay well and keep advancing in the cause of medical excellence. Good night to all of
Thank
you.
you. Good
Thank
night.
you very much.